Good evening, everyone. My name is Professor Jamilu Tukur, and I'm the Vice President one of AFEMSIN and also the Chair of the Scientific Committee. So it's actually 4:30 now, and we're supposed to start, but please bear with us. We'll still grant some little extra time just for others to join us. So please be patient. We did say we'll start 4:30, but please just grant some small extra time for more people to join us. Thank you so much for coming. Good evening, good afternoon, wherever you are from, either from Nigeria or other parts of the world. Yeah, welcome to this webinar organized by the Association of Fetal Medicine Specialists of Nigeria. As you know, AFEMSN has been organizing educative webinars, which take place on a regular basis, usually over every 3 months, for us to educate ourselves and to update our knowledge, and with special emphasis on skills and knowledge that is relevant to the practice of fetal maternal medicine in Nigeria and other parts of the world. So once more, I welcome each and every one of you. I apologize for two things. One is the confusion about the starting time. Some thought it was 4 p.m. It was actually supposed to be 4:30. And I really I'm grateful to those of you that have been patient enough since 4 p.m. Some of us joined since 4 p.m. Now it's 4:30. It's actually 4:36. I think it's time to start. Unfortunately, there are some of our colleagues that are actually attending an inaugural lecture organized by NUTS, University of Lagos, featuring one of our teachers, colleague. And so some of them are attending, but I think we really have to start because it's getting quite late. So for today, we're going to talk about basic anomaly scan. And I think you'll agree with me that this is a skill, a very important skill for all of us as obstetricians and gynecologists. So without wasting time, we're going to invite our speaker. And our speaker is someone who has a lot of experience on this and has actually has become a teacher on this particular topic and has really been impacting very well on a number of us in terms of the knowledge on, and skills of ultrasound scan. So the speaker is none other than Dr. Ibrahim Awowole, and he's from OAU Teaching Hospital, Ile-Ife. And without wasting time, I will give him time to start. Just to say that as he's speaking, we can note our questions and comments, and also use the chat box. I think it's easier for us to use the chat box. And then in the meantime, please, we keep our microphones muted so that we'll have a very entertaining period. So let me welcome Dr. Ibrahim Awowole, who will be our guest speaker for today. Dr. Ibrahim, over to you, please. Thank you. You're all welcome.
Hey, good evening, everybody. Thank you so much, Professor Tupurusa. It's
sorry, Dr. Brian, please, can we have it on slideshow? Your slides, please, on slideshow.
Okay. Yeah.
Thank you.
Thank you so much, Prof. It's a privilege to be introduced by a teacher and very senior professor whom I've always admired. And I appreciate the opportunity to give this, well, I won't say give this, I'll say to lead this discussion, because there are many knowledgeable people in the audience. I was looking through the list and I was wondering if I should continue with the presentation or just ask for a volunteer, judging by the capacity that I saw in the audience. So I'll be discussing introduction to fetal anomaly scan. I appreciate the topic. It's an introduction because fetal anomaly scan is a very large topic, but we will introduce ourselves to it and make us understand what we need to do. So I am Ibrahim Awowole from the Abdominal University. I have no conflict of interest to declare. I will be looking at fetal anomaly scan, considering the aims of it, who should have it done, who should perform it, when should we be doing it if we're doing it, and how should it be done? What type of ultrasound machines do we need to do a fetal anomaly scan? What to look for? This is where we spend most of our time. And then we'll talk about some local challenges in the Nigerian sphere. So Fetal anomaly scan aims to assess for anomalies before delivery. And by doing that, if everything is normal, we may be able to provide a reassurance to the intending parents that the fetus is anatomically normal. Again, it gives avenue for further testing as necessary if an anomaly is detected. Importantly, it provides an opportunity for multidisciplinary team plan of care, including decisions such as place of delivery, the time of delivery, the mode of delivery, the postnatal care. It should not be happening that a woman would deliver and suddenly an anomaly is noticed and will start writing consults and frantically looking for phone calls to call neonatologists or call pediatric surgeons. Whereas these people should have met the parents while she was pregnant, taking her through the likely plan of care. In actual fact, they could take the parents on a visit to the neonatology unit or to the pediatric surgery unit. This is where we will nurse your baby as soon as your baby is delivered. This is the theater. This is where you will stay. So that by the time the baby is born, everybody understands. Importantly, it gives adequate time for psychological adaptation. As I always say, a fetal anomaly scan takes away the surprise factor. No matter how grotesque the anomaly is, understanding what is going to happen helps to relieve some of the anxiety that the intending parents will suffer. And it provides an objective basis for determination of whether to continue the pregnancy or to terminate the pregnancy. Generally, we know that about 2 to 3 per 100,000 births, 2 to 3 babies per 100,000 births have some form of anomalies. And about 1 to 2% may suffer some serious or major congenital anomalies. In some instances, the risk factors are known. In many instances, idiopathic, sporadic. Therefore, if we consider this epidemiological data, we may want to ask ourselves again, who should have an anomaly scan? And the answer becomes very straightforward. Every pregnant woman should have an anomaly scan. And this is why in the settings of the United Kingdom, this is an organized screening program. It's not just not just a random thing. It's an organized program where notifications and reminders are sent to women who are pregnant, telling them an appointment has been booked. It's automatically booked for them to come in and have their scans done to check that the fetus is fine. They then have the option to opt out for those who say we don't want it. We should perform an anomaly scan. The most critical thing here is requisite training. It's a pendulum that could swing either ways with consequences. For people who do not have the requisite training and are performing an anomaly scan, they may end up telling a woman that the baby is normal, whereas there is a major problem. Or they may end up telling a woman that there is a major problem, whereas the baby is normal. Both of these situations have their consequences, which are undesirable. So whoever must perform an anomaly scan must have the requisite training, must regularly perform fetal ultrasound scans and participate in CMEs because it is very easy to get de-skilled. It's a highly skilled procedure. Very easy to lose the skills if you are not doing it. Have access to appropriate referral patterns. It's not right to make diagnosis and there is nothing that can be done for the patient. And there must be routine quality assurance and control measures. This is necessary so that if you tell a woman there is a problem with this fetus, by the time that fetus is born, there must be extra evaluation and documentation. Was the diagnosis antenatally right or wrong? This has to be undertaken for the purpose of quality assurance. Ultrasound equipment. I have said it earlier that the anatomy scan depends heavily on the expertise of the operators. And technological advancement have made equipment available that use color Dopplers, power Doppler, 3D, 4D, spatial temporal image correlation programs. However, I wish to inform us about the 3 T's of anatomy scan. And this involves the technology, which is the ultrasound machine, the technique, and the bridge between the technique and the technology, which is the technician, the person performing the scan. That's the technician, and that is the person that must optimize the technique and the technology, such that in the long run, experts can produce equally good results on medium hand machines. So that machine that is lying fallow without being put to use in our labor ward, in our radiology department, and we keep saying, no, this machine is useless, you cannot see anything. The day somebody with the right skill set grabs that probe, we may be surprised at the results that can be achieved. When should we perform an anatomy scan? Organized screening program is standard care, as I said, in places like the UK. Optimal time is 18 to 21 weeks. It could be done before 18 weeks in selected cases. There are people who have familial or genetic predispositions to some series of congenital anomalies. And in those instances, we may, in fact, move towards doing a congenital, an anatomy scan in the first trimester. For women who had a neural tube defect, for example, people who have had an encephaly before, that's a risk factor for another one, and we can just do that in the first trimester. Again, first trimester cardiac assessment is also becoming increasingly popular nowadays with the right skill set. Detection. This is very important for counseling. Irrespective of the skills and in the best of centers, anomalies may not all be diagnosed 100%. There is what we call the difficulty index, and the difficulty index is considered in benchmarking standardized detection rates. So it is expected that the more obvious an abnormality is, the lower the difficulty index and the higher the benchmark detection rate. So for conditions like anencephaly and gastroschisis, 98% detection rates. Conditions that tend to have multi-systemic involvement like Edward and Fetal syndrome, open spinal bifida, above 90% detection rates. However, when it comes to cardiac scanning, fetal echocardiography, even in the best of hands, up to 50% of these anomalies still be missed. So it is important for us to understand this so that we can appreciate sometimes why some anomalies may be missed, but more importantly, in our counseling of patients, we don't go about saying if there's any abnormality at all, I will book it. But let us make our patients understand that we have standardized detection rates and the major common anomalies we should be able to pick. While doing an anomaly scan, it is good practice for us to perform fetal biometry and confirm the dating, placenta site, and liquor volume. These are all part of level 1 scan for fetal obstetric scan. But please, we should not get extremely fascinated by the anomaly scan such that we forget to document this as part of our routine. The ISWAG has made recommendations for organized training programs approach to anatomy scan. They call it the routine mid-trimester scan. If we follow these abnormal fetal appearances, up to 50. So this is a very useful skill set to have. Each plane has a number of structures to be evaluated and measurements to be taken. And there are specific fetal sections or views that we must aim to obtain. There are 2 overview sweeps and 20 planes for the fetus. I will be discussing this. The initial sweep is a longitudinal head-body sweep to determine the orientation of the fetus. Is the fetus lying straight in the midline? Is it cephalic or is it bridge? We need to know this for the purpose of laterality. You must be able to decide which side is the right side, which side is the left side. Please do not use where the stomach is as the left side or where the apex of the heart is as the left side. There are conditions such as situs inversus, in which case the laterality is switched naturally from the period of embryogenesis. So we look at the spine, sagittal, coronal, and axial. We look at the fetal head. That's planes 4, those are planes 4, 5, 6, transventricular, transthalamic, transcerebellar plane. When you look at the thorax, 4-chamber view of the heart, LVOT, RVOT, 3-vessel view, 3-vessel plus trachea view. All these may not make a lot of theoretical sense to us. So hopefully I will try and bring up some images soon. In the abdomen, a transverse section of the abdomen must show the stomach and the umbilical vein. It must show the cord insertion, must show the fetal kidneys. We must be able to see the fetal bladder and the umbilical arteries. We must be able to measure the 3 long bones in the upper limbs, the 3 long bones in the lower limbs, demonstrate that they have normal relationships. The fetal face, we must see the coronal view of the upper lip, nose, and nostrils, both orbits, and a median facial profile. So I will proceed to showing us images so that we don't, the best way to teach this is by hands-on demonstration. The next best way is by looking at images, as this takes away some of the theoretical components. May I say that there has been some criticism against this approach because it is not systematic. For example, most fetal medicine specialists will start scanning from the fetal head and the fetal face. Interestingly, the moment you finish scanning the head, which is 4, 5, 6, you're going to look at the face, which is 18, 19, 20, before you start to go to the thorax and the spine. So if you want to go systematically in the craniocaudal version, it is difficult to follow the planes as depicted by ISO. I will not be surprised if in the not too distant future, this is all revised. All right, let's look at the pictures. Hopefully this will help us understand better what we're talking about. We'll start with the fetal head. It is good practice to start in the craniocaudal version so that we don't miss any abnormality. We must understand the anatomy of the fetal head, and we must be able to demonstrate that the cranium is intact. That's the echogenic structure we're seeing there. This is the fetal head. The cranium must be intact. The empty rectangular box here is the cavum septum pellucidum, what we call the CSP. There is a white line here, that is the fox cerebri, the midline fox. It must be equidistant, it must be at the center. If you measure from here to the right, to the near field, and from the fox to the far field. The whitish structure here is the choroid plexus that produces the CSF, and it is located within the lateral ventricle. These are the posterior ventricles. There is a tiny slit here for those with Hugo eyes. That is the third ventricle. It measures less than 3 millimeters. This is the normal plane. Now, to appreciate any abnormality at all, we must continue to do so many so that we get accustomed to normal. And this is very important for those of us who do obstetric scan, level 1 scan, irrespective of whether we want to do a fetal anatomy scan or not. Please don't be discouraged. Don't think, oh, it's for the specialists. A lot of mothers who are expectant are referred because somebody was doing a basic scan and kept feeling, why is it difficult for me to get the normal plane? Why is it difficult for me to get the normal plane? But if you don't know what the normal plane is, then the day you don't get the normal plane, you may never understand that it's because there was an abnormality. So this is what the normal fetal head should look like. Now, I have put images here for us to see. On this side is the same image of the normal. And you can see the choroid plexus and the lateral ventricle. The ventricle should measure less than 10 millimeters, and usually it is filled by the choroid plexus. The image in the middle shows us a significantly dilated ventricle. And you can see the choroid plexus, which fills the ventricle normally, now dangling. This is called the dangling plexus because this is already dilated. So this is ventriculomegaly. And if this persists post-delivery, this is hydrocephalus postpartum. There are different causes, maybe obstructive or non-obstructive, and we counsel the parents accordingly. On this side, you will remember I said we see the CSP and a midline pulse in the normal one. Whereas here, there is holoprosencephaly. There is no division. The forebrain is not divided. The only thing you can see is the thalamus on both sides. And this is the most severe form of holoprosencephaly called the A-lobar variant. It's not compatible with life, actually. So these are some of the common abnormalities that we can see on the fetal brain. Of course, anencephaly. This is an abnormality of the fetal skull, not an abnormality of the brain itself. There is a calvaria. The fetal skull is missing. And you will see exposed fetal brain, as seen here, and prominent orbits. This is called the frog eye sign. Prominent orbits, exposed fetal brain. Because I also do 3D scans, I did a 3D of that fetus as well, and you can see that the brain is exposed. There is no fetal skull there, prominent orbits, and this is one of the easiest abnormalities to detect. However, I must be quick to remind us that detection comes with knowledge and the requisite skill sets. So let's keep trying. Let's keep putting our hands on the probe, and let's continue to get used to the normal views. I did mention that we must also look at the transcerebellar plane. The transcerebellar plane is very important. It takes some skills to get it, but the moment we understand how to obtain the transcerebellar plane, which is achieved by moving this probe towards the base of the fetal skull as we approach the fetal neck, and then you see the cerebellum here. It looks like a pair of goggles. Okay, it's dumbbell shaped, and you can measure the transcerebellar diameter. This is one of the most accurate biometries for determining gestational age. The challenge with it is that because it's not affected by fetal growth restriction. So transcerebellar diameter, ensure you can see the cerebellar dermis. The space immediately behind the cerebellum, this is the cisterna magna. And we can have megacisterna magna, some abnormalities like that, the Walker syndrome, and Chiari malformations. You may start to see problems in the cisterna magna. In cases of spinal bifida as well, you may see the banana-shaped cerebellum. And if you are doing your scan in the mid-trimester, you can measure the nuchal fold thickness, just the collection of fluid here, and you get that in the transcerebellar plane. It should be less than 6 millimeters, while the cisterna magna should have a diameter of 2 to 10 millimeters. Now that we can all recognize what the normal cerebellum should look like, let's see whether we can also recognize abnormalities in the cerebellum. Again, somebody was doing some practice and has drawn some lines that are now permanent on the screen. So again, this is the normal transcerebellar view that I just discussed with us, and we can see the transcerebellar diameter, the cisterna magna, and the nuca fold. The image in the middle is a variant that is called the Blake's pouch. And rather than see a clear demarcation between the cerebellum anteriorly and the posterior wall of the cisterna magna, what you see is this cyst occupying the cisterna magna. That's the Blake's pouch. It could be persistent up to about 26 weeks and then rupture spontaneously, and no additional care is necessary. In this instance, however, it persisted in this fetus until about 37 weeks. And understanding that it was there gave us the opportunity to counsel the parents. They were expectant, they knew what to expect. As soon as the baby was born, we invited the physiotherapist to see. And though there were some delays in achieving motor skills and milestones such as neck control and sitting and walking, the fact that we already knew and the baby started physiotherapy at a very young age helped with the prognosis. And that baby is walking now and has achieved considerable motor skills. So this is one of the beauties of having prenatal diagnosis. The parents already know and the team is assembled even before the baby is born. In this instance, there is some atrophy of the cerebellum. You can see the entire cerebellum is missing. And things like this happen sometimes when there are vascular disruptions of the posterior circulation, vertebral-basilar interruption. It's possible that this fetus has suffered a stroke, and you see that that posterior compartment where the cerebellum should be is now an empty fluid-filled space. And we monitored this fetus over a period of a few weeks, and that lesion was a progressively destructive lesion. More areas continued to atrophy and became infected, and the parents eventually decided to terminate the pregnancy due to the progressive nature of that problem. The fetal phase. We must be able to see the two eyes, the orbits, look for congenital cataracts that may suggest congenital rubella. Look at the median facial profile. This takes some skill to achieve, but if you can get the transventricular diameter of that fetus, simply turn your probe 90 degrees and you will be on the fetal phase. This is how to achieve this. We must be able to see the mouth, and the upper lip must be intact. That is the view that helps us to diagnose cleft lip and cleft palate. And this is what I'm talking about. So you can see the midline profile of this fetus. Look at the nose, the upper lip, the mouth, the lower lip, and the chin. All this must be present in the right proportion. There are abnormalities that lead to regression of the chin. So you see hypoplastic chin, like the Pereropis syndrome. So it's important not just to look at the nose and the mouth and the midline and the forehead. We must also look at the chin. So if we understand that this is how the fetus should look normally, then it should not be difficult for us to see. May I just confirm, if Professor Tukusa, is my pointer visible on the screen?
Yes, your pointer is visible.
Confirm that.
Yes, your pointer is visible.
Excellent. Thank you.
Thank you.
Thank you, sir. So on this side, this is an attempt to visualize the midline profile of this baby. And what becomes very obvious immediately is that the nose, where the nose should be, appears to be a depression. There appears to be a depression. Look at the mouth. You can see the mouth of this baby. The mouth here looks so small. And then one starts to wonder what exactly is going on. So because I noticed this, I decided to take another step forward and go into 3D. So I will then show you the 3D images of these two as well. Look at that. This is what a normal baby should look like. You should be able to see the two eyes clearly. Look at the nose, look at the mouth and the upper lip. Lots of hair on the baby's head. Very nice looking baby. This is the 3D of a normal face. But when I did a 3D of the face of the one that I showed you before, you will realize that the orbits are not visible. The nose is not present. The mouth is really small. And then there is this tubular structure at the center of the face that looks like, it's called a proboscis actually. This is a proboscis. So the two eyes and the nose are all fused into a tube, which is a proboscis on the face. And after extensive counseling, and in this instance, I not only had to, in fact, prepare the minds of the woman and her husband, I had to prepare the minds of the labor ward staff, resident house officers, on what to expect. Because we don't want people going on taking pictures and saying a monster was born in OAU teaching hospital. You know, this gave us the opportunity to counsel everybody to say, when this baby comes, please let us treat the baby with dignity and respect. Let us support the parents as necessary. Let's be empathic. And I'm glad this was properly done. So this was what we saw before delivery. After counseling the parents and showing them these pictures, they decided they wanted to terminate the pregnancy. And when the baby was born, the abnormalities were confirmed. So cyclopia is one of the components of holoprosencephaly and is one of the abnormalities you can detect on the fetal face. The lip and nose. This is the upper lip, the lower lip, the mouth, and the chin. As I told us before, if you look at this view in the midline, simply rotate your probe back again 90 degrees and come down towards the fetal neck. And you will end up with this view of the nose and the lips. This is the view that we need to diagnose cleft lip. And if you can see an intact upper lip, then there is no cleft lip. And here you can see the gap clearly. Here, there's a disruption. There's a cleft lip there. In the neck, this is the fetal neck. So what I have done to make this easy to follow is to start from the head and start to go down along the regional anatomy of the fetus. If you go this way, you are unlikely to miss any structure. So we have done the fetal head and the neck and the face. Now on the neck, you can see this multicystic large structure, bigger than the neck itself. These are the clavicles. That's the spine. And that is this huge structure there. That's cystic hygroma. Characteristically seen in Turner syndrome, may also be seen in Down syndrome. The chest should have the cardiac activity present. It should be divided into 3 portions of equivalent proportions. The lung on either side and the heart and mediastinal structures in the middle. We should be able to see the 4-chamber view of the heart, the aortic and pulmonary outflow tract, and there must be no evidence of diaphragmatic hernia. I know that we had one of our webinar sessions on fetal echocardiography and cardiac scanning. So this is just a summary of the things that we need to see. I am not going to spend so much time on this since we already had a full session of that. Nevertheless, this is the lung on one side, the lung on the other side. That is the heart in the center, the 2 ventricles, and the 2 atria. And this is a schematic of what we expect to see. You see this whitish area there, that's the moderator band, and that is what helps us to identify the anatomical right ventricle. The 3-vessel view, 60% of all cardiovascular abnormalities are diagnosed on the 4-chamber view. However, as knowledge advanced and technology advanced as well, it was realized that a lot of cardiovascular abnormalities were being missed because we're not checking the vasculatures, what we call in layman's term the plumbing, the cardioarterial and cardiovenous concordance. And that's what brought the three vessel view into practice. And this is now recommended as a mandatory part of an anatomy scan. So we should be able to see the right outflow tracts, the left outflow tracts, and the right arrangements and size. So let's look at the schematic before we go to the ultrasound image. We'll remember that in the left ventricle, from the left ventricle, the aorta emanates. From the right ventricle, the pulmonary trunk, what is called the main pulmonary artery or the pulmonary vessel, comes out and divides into the right and left pulmonary arteries. And then there is the aorta in the middle, and there's a superior vena cava. This arrangement is very important to rule out abnormalities such as transposition of blood vessels, and it's important that we are able to demonstrate this. Now on ultrasound scan, because the vessels contain blood, you see that they are hypoechoic, and you can see what is illustrated here on the schematic. That's the main pulmonary vessel dividing into right and left. This is the aorta, and this is the SVC. So this is part of fetal cardiac scanning, and it is also now advised that we should visualize the three vessel trachea view. So what I've just shown you now, you still see the main pulmonary vessel, the aorta, and the superior vena cava. In addition, there is an echogenic ring here, which is the trachea. This view is very important because we need it to diagnose some abnormalities as well. I once had a patient who was sent to me from the cardiac surgery unit because they had operated on an older sibling. Then when the woman brought that child for follow-up in the clinic, they realized she was pregnant again. And then Professor Kuni said, oh, now that you're pregnant again, this fetus has a risk of a sibling risk of another cardiac abnormality. Why not see Dr. Awowole and let him do a quick appraisal? And when I scan, remember this is the normal three vessel view that we said, main pulmonary artery, aorta, SVC, and that is the trachea there. But this is the arrangement that I saw, and this is a completely different arrangement. That's the trachea with a vascular web surrounding the trachea. And this is what you see in right-sided aortic heart. And this was used to plan the care for that baby as soon as the baby was born. It's a risk factor for respiratory distress, which may never be recognized if this diagnosis was not made. The fetal diaphragm, that echogenic line that we see here is the fetal diaphragm. And you will see the heart on one side of the diaphragm and the stomach on the other side of the diaphragm on sagittal view. This is the normal anatomy. In this instance, you can see the stomach on this side, and that's because the stomach had migrated from the fetal abdomen to the fetal chest. And you can start to see the stomach behind the heart. Congenital diaphragmatic hernia is notorious because as soon as the baby is born, the baby is active and the baby is attempting to breathe and everything is fine. And then there's a disagreement between the person that conducted delivery and the midwife or the neonatologist, as the case may be, because whoever delivered is insisting that when I delivered this baby, the baby was active. It was after I handed over the baby to you that whatever problems we noticed now started. Maybe your resuscitation skills were not good enough, but that's not the problem. The problem, ladies and gentlemen, is that that fetus will have had a congenital diaphragmatic hernia, which was never diagnosed because the fetus was oxygenated with the placenta before delivery. Everything will seem fine until delivery, when it is now time for the lungs to start to oxygenate the fetus. And so diagnosing congenital diaphragmatic hernia before delivery will be very helpful. It's not very common, about 1 in 4,000, but the day it comes, we need to know. The fetal abdomen, we should be able to see the ribs, the umbilical vein, and the gastric bubble. This is the axial view of the fetal abdomen, and this is also the view that we use to measure abdominal circumference. This is the normal view. Let's look at the abnormal view. You can just see a tiny dot surrounded by an echogenic ring, rather than seeing the prominent gastric bubble. This is what you see in esophageal atresia. In some instances, you may not see any bubble at all, but where you see a small bubble like this is because there is a coexisting tracheoesophageal fistula, and there are secretions coming from the respiratory tract of the fetus into the stomach. Typically, this condition is associated also with polyhydramnios because the fetus is not swallowing. The kidneys. It takes some skills to appreciate the kidneys. They are paravertebral. That's the vertebral body there. That's the vertebral body. This is the kidney on this side and the kidney on the other side. And you can see the renal pelvis as well. You can measure the renal pelvis. It should be less than 6 millimeters. If it is more than that, then there is dilatation of the pelvis. This is the normal view. Now, when you look at this, you can immediately start to see how big this kidney is and accumulation of urine in the kidney. This affected only one kidney of this fetus, and it was due to renal pelvic ureteric junction stenosis. Because we already knew this was happening, the pediatric surgeons came in, counseled the parents, and when the baby was born, they just fixed the baby and everything went back to normal. Now we need to see the cord insertion. And as you see the normal, so once you do that transverse scan of the abdomen that shows the gastric bubble, simply move down towards the fetal bladder and you will get a cord insertion. Please remember that these movements are just about 1 to 2 millimeter movements. Don't move too quick, otherwise you will miss it. And that is the umbilical cord joining the abdomen of the fetus. Look at the gastric bubble there. And this is how it should look like normally. So this is how the cord insertion should look normally. What you need to do is just move down slowly from the gastric bubble, just slowly, 1 to 2 millimeters, and you get to the cord insertion. In this instance, this is the fetal abdomen. And rather than seeing the cord insertion, what you are seeing here is a large membrane that contains the intestine and the liver and the fetal stomach. The stomach is not in this body cavity. It is outside. The liver has also gone out and the intestines are outside. So this was a major omphalocele, and we had the pediatric surgeons review this one before delivery. We diagnosed this at about 27 weeks and put a plan of care in place. And as soon as the baby was born, you see, the beauty is that the moment the baby is about to be born, you talk to the pediatric surgeons, that patient will discuss, they say, oh yes, somebody's on the way. It's always very smooth to manage them. You can enhance your diagnostic acumen. If you also do a Doppler, you will see the umbilical vessels coming out through the cord and nothing else other than the vessels. Whereas in this instance of omphalocele, you will see the vessels coming out alongside other abdominal viscera. This can also be seen in cases of gastroschisis. However, there will not be any covering membranes for gastroschisis, unlike here that you can trace a covering. So this is how you can also use your skill to diagnose additional abnormalities here. And as I've said, the moment you get the transverse section of the fetal abdomen and you get the fetal stomach, simply move fetal bladder 1 to 2 millimeter movement, and you will be able to demonstrate the cord insertion. After demonstrating the cord insertion,
sorry, Brian.
move again another 1 to 2 millimeters, and you will see another hypoechoic.
Yeah, please, I want us to
take his Dr. Cecilia Amotsuka.
Please mute your microphone.
Professor Musuka and Dr. Kolawole Grace.
Yes, and
Thank you. I
Awowole
think they're already working
Lara.
on it now.
Yes, thank you.
Thank you very much, sir. Okay, so once you finish with the fetal gastric bubble, with the cord insertion, move again, just slowly until you see this structure coming up. And this is the fetal bladder, okay? And to confirm that this is fetal bladder and not a pelvic cyst, if you have a Doppler facility, simply put on the Doppler and you'll be able to demonstrate the paravesical vessels, the umbilical vessels, as they move towards the umbilical cord. This appearance gives a confirmation that what you're seeing here is the fetal bladder. Now let us look at an abdominal one. You can see what the normal fetal bladder should look like. And now look at how big this fetal bladder is. This is called megacystis. Was a male child with some bladder outlet obstruction that has led to gross distension of the fetal bladder, such that somewhere here you can start to see the kidney. The bladder was really high up, touching the fetal kidneys. And when this baby was born, interestingly, I happened to be passing by. I had already mentioned it and written there that please let's catheterize this baby as soon as the baby is delivered. Because in actual fact, the fetal abdominal cavity is really small and it has very little room to accommodate extra masses, because this was a mass in that abdominal cavity. And I just passed by and said, oh, okay, the baby has been delivered. How is the baby? I met the person from the neonatology unit bagging the baby for respiratory distress, was trying to ambubag to ventilate. I said, oh, the baby has some respiratory distress. And then I remember I said, I wrote in my instruction, catheterize immediately after delivery. Have we catheterized? They said, no. I said, oh, this may be the reason, because this bladder is so distended that it limits diaphragmatic excursion. And as soon as this baby was catheterized, the bladder was emptied, the fetus assumed normal respiratory pattern. So this again is one of the beauties of making this diagnosis. In this instance, the cause of respiratory distress for that baby was an extrathoracic cause. It was not cardiovascular, it was not respiratory, it was just a problem from a grossly distended bladder. And rather than ambubagging and giving oxygen, the treatment was just to catheterize. And immediately we drained the bladder, everything returned to normal. And the pediatric surgical guys took over from there. So let us get ourselves accustomed to what the normal bladder should look like, and we can make this diagnosis as well. Skeletal assessments. We need to look at the spine, look at the upper limbs and the lower limbs, be sure the number of bones are present, and also be sure that you have the normal relationship. That's the fetal spine. We call it the railway track appearance. And you could see that you must also look at the skin covering it and look for cystic lesions, for undulations. You should be able to see it to the coccyx. And this is the sagittal view. You should do an axial and a coronal view as well for the spine. Look at the upper limbs. Remember the three bones, humerus, horn, and radius. It's important to look for all of them. So I was scanning this baby and I realized that I could have a shadowy image of the arm, the elbow, but the forearm seems to terminate and I could not demonstrate the hand. And then I moved to the other side and it was the same as well. So I switched to 3D and I was able to demonstrate the shoulder, a short arm, the elbow, again, the forearm terminated. Did not continue as I would have expected it to continue. And so we had to discuss this with the parents. This is fetal arterial syndrome, affected both upper limbs. There was coexisting duodenal atresia in this fetus. It was a multisystemic abnormality. And when the baby was born, that was it there. So it was indeed fetal atresia. So let's pay attention to, don't think, oh, the face is important or the brain is important. Every part of that fetus is important. That fact, anatomy scan is a test of patience. Now to the lower limbs. This is how the leg, that's the ankle, the leg, that's the heel, and that is the foot. You should see this when you do an anatomy scan, and the relationship should be preserved. When you look at it laterally, that's the way it looks. And you can look at it from the anterior view as well. From the ventral view of the lower limb, that is the thigh. This is the knee joint. That is the leg. You can see the fibula and the ulna, the ankle, and it must continue straight. If you are looking at it from the dorsal view, the anterior-posterior view, the foot is a straight continuation of the leg. It's when you look on the lateral aspect that you will see this. In this instance, however, I hope we can appreciate this. It becomes a problem when you see the leg and you start to see the foot beside the leg. The foot should be a straight forward continuation of the leg, but in this instance, the foot is bent, and you can see that foot coming beside the leg. This is in fact petatalitis, equinovirus. So, gender determination. It is in cases like hemophilia, where you know that it's an X-linked condition, it is very important to determine the gender. Consider the interest of the parent as well. If they want to know, it's good practice to tell them if they want to know. If they don't want to know, please respect their wishes. However, if it is difficult to get the fetal gender, in line with the ALARA principle, which is as low as reasonably achievable exposure to radiation, then please do not spend too much time on this unless there is a reason for it. Useful tips. Avoid the tick box phenomenon. If you have not seen it, please say, I can't see it. Tell the woman to wait and return, book another appointment, but please do not assume that since every other thing I checked was normal, the one I didn't see will also be normal. It may in fact be that you did not see it because it was abnormal. Emphasize that some anomalies may be missed. Some anomalies evolve as the fetus gets bigger and matures some more. Things like arthrogryposis, congenital contractures, okay, problems, cardiac anomalies. The VSD may be small initially, but may be more apparent as the fetus gets bigger. And then some anomalies develop as the fetus also advances in age, such as hydrops. So it is good practice, and I almost always do it. I see the patient again after the 20-week scan, maybe in another 6 weeks, 8 weeks, just to be sure nothing else has developed, and confirm that the fetus remains normal. Please, let's remember that a normal scan does not completely exclude all anomalies. Why is that? Some problems are functional, some are genetic, some are chromosomal, and they may not manifest until the baby is born and starts to grow and could not meet milestones or has some peculiar tendencies. So let us always remember to write this. And I always put a disclaimer that a normal anatomy scan does not rule out genetic abnormalities that may not have structural manifestations. This is very important. What are our local challenges in Nigeria? We still don't have enough manpower to have an organized fetal anomaly screening program. So at the moment, we do it selectively for women who are at high risk. When we find problems, there are communication skill modules that we should undergo, training on breaking bad news, bringing that parent from the position of despair to the position of hope, how to communicate with them so that they can take informed decisions. Some of us still don't appreciate the fact that the decision on what to do with that pregnancy is for the parents to take, not for the doctor to take. Sometimes we see things that we don't know what to do or how to interpret them. Laboratory backup to do genetic testing is still a problem. I hope we are working on this to see if we can have established referral pathways to do karyotyping and fetal genetic sequencing in Nigeria. And establishing a fetal medicine MDT in my institution has been very helpful. One would be amazed at what the neonatologist or the radiologist or the pediatric surgeon can bring to the table. Nobody knows it all. So discussing with these people was something that we need to get used to. We need to stop calling pediatric surgeons and neonatologists after the babies have been born. We need to be able to work together and bring the patient along as a critical member of the team, along with our significant others. So I think I need to acknowledge my department that has given me the necessary training from undergraduate days to internship to residency and now as a consultant. The perinatology unit has been extremely supportive. I must acknowledge them as well. I've listed their names there: neonatology, pediatric surgery, fetal medicine, MDT. I must especially thank AFEMSIN for giving me this platform to speak and for the encouragement over the years. The organization is AFEMSIN, but it's beyond organization. We're like families. These are people who have been monitoring the progress of some of us from years back. And of course, the most critical of all, our dear patients who have entrusted us with their care in this journey. I think the last thing left for me to do is to thank you all for listening, and we'll quickly take questions if there are any. I will hand over to Professor Tsukuri.
Thank you very, very much, Dr. Ibrahim. All of us will agree that Dr. Ibrahim is someone who knows this stuff, and he was delivering it in pulses, but importantly systemic from head to toe in a simple manner that I think is quite helpful and has made this skill look achievable by each and every one of us. Thank you so much, Dr. Ibrahim. I don't know how to do electronic clapping, but I'm sure every one of us is clapping for you. And really, we really appreciate this. Thank you very much on behalf of AFEMSIN. If you have water near you, Dr. Ibrahim, please take a sip. We'll get back to you. We have some few questions, but before then, a lot of us are here, and this is, like I mentioned in the introduction, this has been organized by AFEMSIN. AFEMSIN is Association of Fetal Medicine Specialists of Nigeria. So I think we'll use this opportunity to give the Secretary of AFEMSIN, Dr. Bolurin, who is here with us, the chance to make a very short presentation. Dr. Ibrahim will take questions thereafter, so just take some sip of water. We'll get back to the questions. All right, Dr. Ibrahim, kindly allow Dr. Ehelaye the chance to share. There's a small slide he wants to share. Okay. So, Dr. Ehelaye, please go ahead. You can share your screen now. Are you with us? Dr. Ehelaye, please. Well, okay. So while he's getting ready, please let's keep our microphone. We'll soon finish, please. Okay, sorry. I think Ella is about to start. I'm seeing his screen coming up. Yes. Please, let's keep our microphones. Dr. Bolurin Ehelaye is the Secretary of AFEMSIN. He has the floor. So please go ahead. Dr. Hela, we're not hearing you. Please mute yourself and speak. Am I the only one not hearing him?
No, we cannot hear.
Okay.
Thank
Okay.
you.
We are not hearing him more.
Okay, fine. I will try to reach him and find out what's happening. But in the
His
meantime,
mic is muted, actually.
sorry?
His microphone is muted.
Okay. Please unmute yourself and speak.
We are not hearing him.
Are you hearing me now, please?
Yeah, we can hear you. Go ahead.
Yeah.
Thank you very much. Thank you. Yeah. We are all welcome to AFMC. AFMC, as we know, is the Association of Fetal Maternal Medicine Specialists of Nigeria. We were established in the year 2011, and gradually and steadily we have grown over the years. We have become what we are now, that have now attracted so large a number whenever we do our webinars. I will not want to take much time. I think the evidence speaks for itself. This webinar is an evidence that we are an organization that has to be reckoned with in obstetrics and gynecology. I will go straight. How do you join us? Joining AFMC falls into two categories. You can either be a full member or an associate member. Full membership is exclusive to fellows in obstetrics and gynecology that have either obtained the fellowship of the West African College of Surgeons or the National Postgraduate Medical College in obstetrics and gynecology, or its equivalent. For full membership, what it takes at the time of registration is only 30,000 naira. 20,000 is a one-off membership registration fee, and then with 10,000 naira for the annual due for the year. In this year now, we will say 10,000 for 2023 annual dues. From then onwards, the obligation of a full member will be to pay the yearly dues, which for now is 10,000 naira. Okay. For associate membership is open to obstetrics and gynecological residents, but it's not exclusive to them. In fact, who can be an associate member? I think anybody who loves to reduce maternal and perinatal morbidity and mortality can be an associate member. So apart from O&G residents, is open to residents and fellows in other specialties like our other allied specialties like radiology, pediatric neonatology. You've had Dr. Awowole talking about the pediatric surgeons and all others, because we are all stakeholders. The others include sonologists, counselors, geneticists, our nurses, our midwives. You can see when he was discussing, there was a lot of talk about the labor ward, and the labor ward is not only about obstetricians, it includes all these ones. For associate members, they pay half the dues of full members. For now, it is 10,000 naira one-off associate membership registration, and then 5,000 annual due for the year of registration. That is at the start 15,000. That is subject to review for now. From then onwards, the obligation of an associate member will be to pay the yearly annual dues, just as applies to full members. One thing, and I think this is one innovation that I think has put us now in the limelight, is that we have membership certificates that are now being issued to members. The first batch of members have received their membership certificates. It's a very beautiful certificate containing your name printed out, as well as your membership identification number. Usually that is assigned to you based on when you registered, your name on the register, on the roll. For obstetrics and gynecological residents who register as membership, as associate members, once they become fellows and it is confirmed, their registration will be upgraded to full membership, meaning they will get another certificate. But one thing that will not change, they are already members of AFEMSIN. Their membership numbers remain with them for life. How do you register? The first step, the preferable way, which because everything is going digital and we need to have a good database, online registration is what we prefer. And the way where to go is our website, afemsin.org. It's a straightforward. You type it and you'll find yourself there. On the top, you will see the top icons. There's a home icon, then there's a membership icon, and then there's a dues icon. Use that membership icon on the top. Okay, there are some other icons you see. We're still trying to do some upgrading under membership that are below or registered. Those ones are not really functioning like the one up. That one after the home icon, membership, you go in there. When you go in there, you will see full membership registration, associate membership registration. You pick whichever category that you belong to and you log in and you go in. The beauty of the online registration is that it's going to capture you at that point. Before you even start paying, you will register and it's captured in the database. After that, then it will ask you to pay and then you can pay online. Now, what we have been doing for many people, and that the window is very short, very soon it will be phased out. In fact, everybody who registered directly will eventually get an email telling them to come and register, because if you don't register, eventually you will be denied of some privileges on the website. But that there's still a short window for that. That is direct transfer, and that you can go through our account details as you are seeing above. Association of Fetal Maternal Medicine Specialists of Nigeria, Access Bank 071 051 4709. If you use that, the only way we can know you have registered because you didn't register online is if you are able to send a direct evidence of payment to the treasurer, or you can also send to me, the secretary. Why not come and join us? Thank you very much.
Thank you very much, our secretary, Dr. Bolurin Ehelaye. I think you've all had it, the ways and various ways you can join us. We want to welcome more and more members. So thank you very much. Let's go back to the presentation by Dr. Ibrahim. We have some questions. There are so many requests for this presentation. That is understandable. A lot of us want to take time to digest the various high load of stuff that has been presented. So what we'll do is that we have a number of social media handles on our, including our website, and the information about that is on our website. So we'll put this presentation there, and you can have access to it on our social media handle, including Facebook. So we'll put it, and we can all access it there. I can see some few questions. Dr. Ibrahim, I believe you are with us. There's a question asking that
to help you out.
Kindly repeat.
So what you are trying to do is to stop resisting yourself.
Okay, to Olayinka, please mute your microphone. Okay, Dr. Ibrahim, somebody is asking, kindly repeat how to identify the right and left side of the fetus when we're doing our scan. And then there's another, the second question is, can you recap 3VV? That's what the person wrote. Can you recap 3VV? So these are the two questions I have. Dr. Ibrahim, over to you. Dr. Ibrahim, are you with us?
Thank you very much.
Dr. Ibrahim?
Somebody's microphone.
Exactly.
Somebody's microphone is on.
Dr. Ibrahim, can you hear us?
Okay. Yes, I can. Can you hear me, sir?
Yeah, the questions, Yes, you have been asked to repeat how to identify the right and left side of the fetus when we're scanning. And then somebody's
Can you hear me,
asked,
Prof?
yeah, I can hear you. I don't know that you're hearing me too.
I can hear you perfectly, sir. So I have the two questions, and I'm just looking at. So the three vessel view. The important thing is to understand the three vessels that we'll be looking at and how they are arranged, the arrangements and their sizes. This is how they come out of the heart. So the one that comes from the right ventricle, that is the main pulmonary vessel. And that's what we see here. That's the main pulmonary vessel. After the main pulmonary vessel, okay. So after the main pulmonary vessel, the one in the middle is the aorta. Dr. Ayala, please can you mute your microphone, sir?
Okay.
Thank you, sir. Okay, so the biggest of them all, which comes out as a single vessel, left pulmonary artery, so right and left here, and then the L, this arrangement, then that fetus does not have transposition of great arteries. Because if there was transposition of great arteries, what you will see are two vessels running parallel to each other. So you need to get this arrangement and see these three vessels to be able to identify normality and exclude transposition of great arteries, TGA, in the fetus. With respect to laterality, what we need to do at the beginning for people who are moving from level 1 to level 2, what we always advise them to do is to have a door by the side of their machine, so that what you need to find out where is the head and where is the back. If the fetus is cephalic, with the head towards the maternal bladder, and the back is on maternal left, then the fetus is facing maternal right, and the left side will be downward and the right side will be upward. If the fetus turns the other way, then we know that this has shifted as well. It takes a bit to get used to determining laterality, but the shortcut to it is just have a gun, some of those ones that we buy for our kids, put it by the side of your machine. Everything I have said will reverse if the fetus was breached, because the head would then be on the other side and you have to flip the doll over again to see where the right and the left is. But after doing that for some time, you can just imagine it on your head. The funny bit of it is that as you are transitioning from doing it often and using the doll, sometimes you see some of us scanning and trying to bend this way or that way because we're trying to assume the position of the fetus so that we can determine laterality. If you see that, please don't laugh too much. It may soon be your turn to do it as you step up in your scanning program as well. So this is how we determine laterality. As I said earlier, please do not say wherever you see the heart is left, wherever you see the stomach is left. There may be dextrocardia, so you may see the heart on one side, the stomach on the other side. Or there may be complete situs inversus, in which case the heart and the stomach will all move from the left to the right. And we may miss an abnormality if we just assume that because they are on the same side, the laterality is preserved. So you have to look at the fetal spine and look at the fetal head, and you'll be able to determine which is right and which is left. Those are the two questions, Prof.
Yes, there's one more, and I think that should be the last, talking about reporting. how do we report congenital fetal anomalies?
Okay, so reporting obstetric ultrasound is a topic on its own, because even for normal scan, we see a lot of funny things. The fetus was alive. It can't scan, it has to be written in present tense, because it's a real-time imaging, unlike the cross-sectional imaging of scan and MRI. And one must have all the necessary structures. So if it goes systematic the way I've gone, it's unlikely you will miss it. But the best thing is to have a template or a checklist. And ISWAG has prepared a checklist. We can go to the ISWAG website and download this for free. And it's encouraged for use. No copyright is held on it. So in fact, sometimes if you miss something because you are ticking, saying, not saying, normal, abnormal, you may have to go back to the patient to say, oh, I have not seen this one. So what I would advise for those of us who are starting to get into it is to download the ISWAG checklist, and all the structures we need to check are listed on the checklist. It's a very useful resource for us. That's my recommendation.
Thank you very, very much, Dr. Ibrahim. And that brings us to an end of this educative webinar. I believe each and every one of us has gained. And like I said, AFEMSON has been organizing this, and we do that. We organize these webinars at least 4 times a year. So the next one is planned for sometime around December, God willing, and it's going to be on sickle cell disease. Will be delivered specifically by the president of AFEMSON herself, that is Professor Afolabi of Lagos University Teaching Hospital. So we look forward to the participation of each and every one of us in the next webinar. Meanwhile, Dr. Ibrahim, we really appreciate all our various participants from all over, both in Nigeria and other parts of the world. Really appreciate your presence, your patience, your contributions, and we look forward to hosting you another time. Thank you, everybody. Good night, good evening, good afternoon. Looking forward to seeing you another time. Thank you. Bye, everybody.
Thank you, sir. Bye-bye, everybody.
Thank you, Dr. Ibrahim. Bye-bye.
Thank you, everybody. Bye-bye.
Thank you, Ibrahim. God bless you.
Amen. Thank you, sir. Bye.
Thank you very much, sir.
Thank you very much, sir. Very educative. Thank you, AFEMSON.
Thank you very much, Chief. Thank you very much.
Bye-bye, everybody. Thank you so much, Dr. Awowole.
Well done. That was
Thank
good.
you.
Thank you, Professor Tukur.
Chibuka, my regard.
Yeah, thank you so much, Ibro. You did a good job. Thank you very much.
Well done, Ibrahim. That was good. Very great.